glorious morning it is, eh? Wonderful weather. Good for your health. So we thank the Lord for this another opportunity that we can be together in this fashion, and we thank God for the privilege of having so many doctors come in and be sharing with us, thinking and being concerned. And we thank God for the call on their lives. I believe to be a doctor is more than just a job or profession. It is ministry. I want to read a scripture from 3 John 1:2, and it's the Apostle John as he's addressing the church. Beloved, I pray that you may prosper in all things and be in health just as your soul prospers. Isn't that wonderful? And that's the desire we should have for everyone, really, as believers. I was just thinking about, if you can hear the difference in my voice at the moment. I just come from Israel, and just a change of temperature, and I've had all this coughing and all kinds of things. I thought, Lord, I'm going to have a group of doctors. But this was on early Friday morning, and there wasn't a doctor around, and I remember this verse. Lord, you desire that we prosper and be in good health as our soul prospers. And I just had a really encouraging and uplifting and exalting time in Israel, even seeing what's happened, the fulfillment of prophecy. And I thank the Lord so much that in every area of ministry for us, that he has imparted himself into us. And it's amazing. I remember when I was in hospital 4 years ago and had all the results that I wouldn't be able to function again, have to have bags and all this for the rest of my life. You know, there was a nurse that was having to come and check my blood and stuff like that, but she never would look in my eyes. And one day my sister was there, and I said to my sister, do you know this lady never looks in my eyes? And then she heard me say it, and I said to her, she looked at me, and as she looked at me, she was just about to take some blood, and I just touched her hand, and I said, do you know that you're serving God's purpose? And she just kind of stunned. And I said, yes, you're serving God's purpose. And you're serving God's purpose by even serving me. And all of a sudden, I said to her, you know that God loves you, and I appreciate what you're doing. And right there and then, tears start coming down her eyes. I don't know what she was going through, but even everyday people have to be working on everyday situations in people's lives, and they could be doctors or nurses, but they have their own issues they have to deal with. And do you know what happened? They moved me from intensive care, and so I didn't see her again for another day or so. But after that, every single day, she would come and find where I was and walk in and say, like that. And I'll never forget that, and I had the opportunity to share in Jesus with her. In whatever function we are in life, we need the Creator. And it's his creative power that works through us in all different ways. And so I just want to say, beloved, I pray for you today that you will prosper in all things and be in health just as your soul prospers. Let's pray. Father, I want to thank and praise you so much for your love and your grace and your mercy. And thank you for giving us this opportunity, Lord God, that we can be together in this fashion. I want to thank you for your deposit in the lives of these precious doctors. And Father, all those who will be taking part today concerning our medical care and health, thank you because you're the one who gave us life. And thank you because you're the life giver, Lord. You impart knowledge and your wisdom and your care so it could be administered to us in all the ways we need it. So we commend this time to you and to your grace. In Jesus' name, amen. I'm asked to advise you that there will be question and answer panels after the talks, so they can ask questions, so you can ask questions, I guess. So if you write the questions down, I'll get this right, on the post note, there's some post notes there. Yes? So if you have some questions or whatever, write them down. If I'm saying it wrong, Dr. Cheryl is coming soon, so she'll put it right. And so, and just place it on the clip chart. Clip chart there. So yeah, if you have any questions or whatever you want, yeah, write it down here and then stick it on the clip chart there. Amen. Now, it's a great honor to have the first doctor that's going to come and speak is one from in-house. There's a doctor in the house. And it's Dr. Cheryl Clarke, and she's here with us, and she's going to come and share about general screening. Yeah, and it's wonderful because I saw her in Israel. And she's back here. God bless you. Let's welcome her as she comes.
Okay, good morning, church, and thanks for all those that have come out today. So we're kind of splitting the talks. Me and Dr. Tosin, we're going to cover more tips on female health and screenings that are available. And then we are going to have some other doctors later on, Dr. Danielle and Joshua, talk on men's health. So we're just going to talk about different types of contraception for females, the advantages and disadvantages of the different types of contraception, and then we're going to touch a little bit on the menopause and what this means for female health. So just a little recap. I know all of you must know about the menstrual cycle, but it's good to understand what good physiology is, to understand what pathophysiology is. So as we know, the menstrual cycle, it lasts over 28 days for most women. It is split into two phases. So we have the follicular phase, which the main hormone that predominates there is the estrogen hormone. And for the second phase, we have more the progesterone. And in between those two phases is where the woman ovulates and produces an egg. Now, not all women have a 28-day cycle, and that's because the follicular phase, the first part of the cycle, let me just get a picture so it's easier to show you. The first part of the cycle, that can vary. So it might, for some women, that might be 14 days. For others, it might be 18 days. And this is where women might struggle with ovulation, knowing the timing, if they're trying to get pregnant, have a child. They might think they are just a 14-day first part of their cycle and not realize actually the first part of their cycle lasts for 18 days, 20 days. And then, so they will miss time when the egg is released mid-cycle. The only part of the female cycle that is set is the second part, which is what we call the luteal phase. So that's the second half of the menstrual cycle. We know that's always going to be 2 weeks. So the best way for a woman a childbearing woman who's trying to have a child, the best thing for her to do is to count from the back of her cycle. So if she knows she normally bleeds every 28 days, bleeding is the first day of the cycle. The first day she bleeds, that's day one. If she knows she's 28 days, fine. She can go back 14 days and know day 14 of her 28-day cycle, she will release an egg. Of course, if she has a prolonged cycle, more than 28 days, she's just got to subtract 14 days from the end of the cycle. I hope I've not lost anyone. Okay, good. So we're just going to talk about some of the different contraceptions that are available out there. I know this is common knowledge, but from the patients that we have, you can tell that there's a lot of misunderstanding sometimes of how contraception works, side effects, and especially if a woman of childbearing age is trying to have a child, they might not understand the reversibility of contraception. Some contraception that is used can be reversed straight away. Some could take up to a year. And women are not always well advised. I think we're quite quick to put women on a pill for birth control, but we don't always have more than 10 minutes to explain everything. See some of my doctors laughing. Yeah. So we've got the oral contraception pill, the intrauterine device. I'm going to talk a little bit more about that one. Progesterone implantation. These are just inserts that women get place in their arm. And with the progesterone, you'll see that women will really blow up in weight, a lot of fluid retention. Some of them have developed acne. And with the estrogen-containing pills, again, if a woman's got other, what we call comorbidities, other ill health conditions, they may be at risk of having an estrogen-containing pill. There was some articles a few years ago where there were young women that were dying on the pill from clots. And again, it is a low risk. I'm not here to scare anyone, but I'm a firm believer that patients should be well informed before they put anything into their body. There's always natural methods. That's not going to suit some people, but there is the option, and then you've got barrier methods. So just talking a bit more about it's really tiny on that screen, sorry. The combined oral contraceptive pill, like I was saying, not only are some of the pros is that it is reliable in inhibiting pregnancy. If you don't want to be like my grandmother's day and have more than 10 children, then of course, it's reliable in that respect. But it is still important to understand the cons of it as well. Now, some of the cons of the combined oral contraceptive pill is that it can cause cardiovascular risk, an increase in blood pressure. And this is why any young woman on a combined pill has to have her blood pressure checked every 6 months, because that is something that can get missed quite easy. And then it can, like I said, there's young women, there's been cases where they've died from thromboembolic clots. Also, the pill can interfere with how we metabolize our carbohydrates and sugars, so it can cause women to be pre-diabetic as well. Some women, the pill helps with acne because of the hormonal balances. With other women, it can cause acne. So this, again, it has to be catered one-to-one. If it's not suiting you, you need to speak to your own GP. And then we've got psychological effects, effects on the liver, such as gallstones. And if ever you suddenly develop an infection or you need any other medication, especially as a young person who's probably not very ill and just on the pill, people are on the pill not just for fertility, for contraceptive purposes. They can be on the pill because they're suffering with acne. There's other reasons why some women might be on the pill, but you have to let your doctor know if you're on other medication because it can interfere. So a little bit about IUCDs, intrauterine copper devices. Now, these became quite popular when there was a lot of talk about some of the negative effects of estrogen as a contraception, especially with women that have adverse effects, or it doesn't suit them because either they're a smoker, they're overweight, they suffer with headaches, any of these risk factors, they can't be on the combined pill. So we then had the intrauterine device that came out. So there's more than two different types, but I'm just going to focus on two. So you have the pros is that once a coil goes into a woman's womb, if the woman decides she actually wants to try for a baby, it will be immediately reversible. It can be used long term. Some women use it for like 5 to 10 years, and it's non-user dependent, meaning it's not like the pill where you have to take it at the same time every single day, because some women are not really good with routine, and then they end up having unwanted pregnancies, resulting in abortions, miscarriages. So some women would prefer to not have to think about it and just have this device in their womb. Now, some of the cons is, like I said, you would need a professional to insert it. Periods can be a bit more heavy and painful sometimes, and it doesn't offer protection against infection. You'd think that was common sense, but common sense isn't common anyway. Just talking about some of the health risks. Now, with the coil, it is associated with miscarriage if a woman actually becomes pregnant whilst the coil is inside, because of the hostile environment that the coil produces in the womb, it then can cause a miscarriage. The whole point of the coil was to stop fertilization, but this is the thing, we cannot offer 100% guarantee. So this is where problems happen now. So you have fertilization, the egg and sperm fertilize, and it travels from the ovaries. Let me just show you a picture, actually. Oh, no. Yeah, it travels from the ovaries, the yellow bits at the end, travels up the fallopian tube, and then it inserts into the womb. Now, what happens with the coil? This is a coil in the middle of this woman's womb. Because the coil is in the majority of the womb. The womb is quite small, actually, until implantation happens and pregnancy progresses. The womb is quite small. And so what happens, a lot of these fertilized eggs end up in the fallopian tubes, and they're what we call ectopic pregnancies. And some women will just present with shock. The tubes can just burst, and they just bleed out. And it can be hard to diagnose sometimes. So that's important to know the side effects with that. Just going back a minute. So here we got two different types of coils that are inserted now. One is based on hormones, mainly on progesterone. That's the green one. Now, how that works in the womb, it thins the lining of the womb so that even if a sperm makes it to an egg and fertilizes, because the lining of the womb is made so thin, it prevents implantation. But it doesn't 100% guarantee that it will prevent fertilization. So for those who are of Christian belief, of where we believe life begins, does it begin at conception? Does it begin when the coming together of the egg and the sperm is a zygote, an embryo, or a fetus? Some scientists have the argument of actually we only class life at the point of fetus, which is like going past 8 weeks. But for those who believe all life comes from God and believes the point of conception is when egg and sperm meet and fertilize, then you've got to understand in some cases, and a lot of women are not aware of this, it can almost be, and this is debatable actually, we're still arguing over it, can this be classed as a type of abortion? Because you've not prevented fertilization. It's meant to stop fertilization, but it doesn't always. But what we are now doing, we're preventing implantation of a fertilized egg. So we just need to be aware of that. And then we've got a copper into uterine device. That releases a spermicide to kill the sperm. Again, so much sperm is released, you're not going to kill them all. So some of them will escape the chemicals, and they'll find that egg and fertilize. So again, that is how that one is used. It tries to create a hostile environment in the womb for any survival, but it doesn't always work, and it's just important to know that. So just going to touch now a bit. Sorry, the other reason I've mentioned the combined estrogen pill, etc. I'm not going to go too much into it because Dr. Tosin is going to talk more about different risk of different cancers. But we have a phenomenon called unopposed estrogen, where basically if we allow the womb to be constantly exposed to only one level of hormone and not the balance of the opposing hormone, because the womb is constantly proliferating, regrowing, it puts the womb at risk of making mistakes, which then can become cancerous cells. So that's the other reason. Contraception is there for the reason it's there for, but we need to understand there is a small risk of some uterine cancers as well. So we're going to quickly talk about the menopause. Does anyone know how I'm doing for time? Am I okay? Okay, fine. So the menopause. So menopause is a biological stage in a woman's life when menstruation stops permanently due to the loss of ovarian follicular activity. So basically, when the ovaries stop producing eggs. So a woman is born with all of her eggs. She doesn't, of course, menstruate until after puberty because that is put on pause. So, and then from puberty, every month an egg is released, unless, of course, a woman's on a pill or different reasons. So when it gets to menopause, that's it, game over. No more eggs. I'm only teasing. So basically, so it occurs with the final menstrual period, and it usually is diagnosed after 12 months of amenorrhea, just means you've not had a period. Some anorexics or women that are underweight will not see their periods as well, so it's important to know if a woman is not above 45 and she's experiencing that, it might not be she's entered into early menopause, it could be that she's simply underweight. So in the UK, the mean age of natural menopause is 51 years old, although this can vary between different ethnic groups. So stages of menopause, you might hear women talk about some of the premenstrual symptoms, cramps, irritability, difficulty sleeping, and one of the things that really irritates women with the menopause is that they get this sudden burst of progesterone, and progesterone increases the body by an extra degree in temperature. So if our body temperature is sitting at 36.5, when you get that burst of progesterone, you suddenly go to 37.5, 38, and that's what women can't take. So then you've got perimenopause. So that is now, a woman's not seeing her period every 28 days, or if their cycles every 35 days. They're just seeing it every few months. So they know, okay, they're heading towards menopause, but they're not fully in menopause until they've not seen a period for 12 months. So again, the common hot flushes, loss of libido, and then menopause actually kicks in. Now, during the time of menopause, because now there isn't as much estrogen, which keeps certain organs lubricant, such as the vagina, there's also breast cancer risk as well, depression. It's important to understand there are ways that women can combat some of the symptoms of menopause. So I'm going to talk a little bit about hormone replacement therapy now. A lot of women don't want to go through the symptoms of menopause, the dryness of certain parts of the body, the mood swings, the sweats. So they will see their GP and they will ask, can they have hormone replacement therapy? Now, there's been a lot of study, and I'm not going to go into it now, I don't have time, but basically it's just to be made aware that systemic hormone replacement therapy does carry a small risk of breast cancer. So what women don't want to do is try to jump out the pan into the fire. They need to be aware that actually it might be easy, it might just pay off to just ride through the symptoms, but they can have like topical, when I say topical estrogen, so it's like cream you just put on your body. So whichever part of the body is affected, they could just have the hormone in a cream, and it's less risky of developing. Actually, there's no association, actually, I've read in the research that it puts any woman at high risk of breast cancer, but those who take the oral, through the mouth, take the tablets, they're at high risk of developing breast cancer. So some of the health risks that increase during menopause is osteoporosis, so weak bones. Estrogen plays a very important role in bone density and strength. So we advise that women look at their diet and their exercise, because, I mean, I've seen a lot of patients, I'm sure you have as well, where they've just had stress fracture, they've not had a fall, they've just walked, and they've had a fracture. And then, you look, they're postmenopausal, they've had their menopause, and they've never looked into their bone health. So it's really important to do that. If you get a chance with your GP, you can ask for MOT blood tests and check that out. And then women, estrogen protects women's heart health more than, because men don't have estrogen, of course. So men have a higher cardiovascular risk of, say, developing heart disease, heart attack, than women do. Now, the minute a woman goes into menopause, because she's got reduced estrogen, she shares the same risk factors as a man. And then again, because of obvious reasons, they're more prone to urinary tract infections because the organs, such as the womb and the ovaries that were there for obviously for procreation, for having a baby, they shrink, they atrophy. So women have to do a lot of pelvic floor exercises to keep their womb area strong. And the other thing to be aware of as well in terms of identifying cancer risk really early, if any woman has established menopause and she's not had a period for 12 months, and then she suddenly starts to bleed, we call it postmenopausal bleed, that it could be, there can be a few non-serious reasons for that, but one of the main reasons for that could be uterine cancer, a cancer of the uterus. So it's very important that a woman doesn't ignore such a sign and presents early, because she could always have a hysterectomy or whatever, it can be identified quickly rather than it spreads and to the point of no return. Another menstrual irregularity to look out for is bleeding in between your menstrual cycle. That again is a red flag. And bleeding straight after sex is another red flag as well. So here are some of the benefits of estrogen. I've already talked about how it supports our bone health. So I'm not going to go on about that because Nikki will explain how you can support that. And then one important mechanism by which estrogen is thought to protect against atherosclerosis. So that's build-up of plaque acid in the arteries. We've got blood vessels that supply the heart, the coronary arteries, and then the rest of the body. Now, estrogen is thought to protect against some of that plaque build-up. So the minute a lady stops having so much estrogen in the body and enters menopause, she needs to be mindful that she needs to look at her cholesterol, look after her cardiovascular health a lot more. So how can we mitigate these health risks? Osteoporosis, weight-bearing exercises, cardiovascular disease, lower your cholesterol, good exercise and good sleep, minimize the use of hormone replacement therapy, except for if a woman's entered into early menopause, because she will need the hormone replacement therapy so she doesn't lose all her bone mass. And topical use is fine, topical on-the-body use is fine, sorry for some of the terminology. And then pelvic floor exercises. That's my references. Thank you.
Good again. Now, is Dr. Tosin here? Ah, good. Okay, let's welcome Dr. Tosin.
Hi, good morning, everyone. Well, it's just about still morning. So I'm Dr. Tosin, I'm a GP. I work in Surrey and Kent. So this morning, I will be talking about breast and cervical cancer screening. So we'll start off by talking about what breast cancer screening actually is. So essentially it's a mammogram, which is a type of X-ray. They take an image from above and from the sides of each breast, so you get in total 4 images. Most of the time it's done at mobile testing units. You see some of them near supermarkets and also in hospitals. Essentially the purpose of it is to help detect cancer at its earlier point, because the earlier you catch it, the quicker you get treatment, the better the survival. Of course, there's X-rays, so there's a very small amount of radiation, but it's less radiation than you would get on a transatlantic flight, so just bear that in mind. The reason screening is so important is breast cancer is the most common cancer in the UK, taking up about 15% of the chunk. Screening saves around 1,300 lives each year in the UK. And of course, we find the majority of those diagnosed with breast cancer are over the age of 50, as risk tends to increase with age. So we'll talk about who's invited. All women registered with a GP aged between the age of 50 and 70. So please make sure you're registered with a GP. Your first invitation will usually be between the age of 50 and 53. So don't be alarmed if you're over 50 and you haven't quite been invited yet. It might be on its way. It's automatic. It's sent by the post. So it's every 3 years you're invited for a mammogram. But there is screening for those who are younger than 50 if they are at higher risk. So, for example, if they have a family history of breast cancer or particular cancers, I will go a little bit more into family history risk. Or if you've inherited a faulty gene, such as you might have heard of the BRCA gene, there's also the TP53 gene as well. So you get screening at a younger age and more frequently as well. There is no preparation needed, you just show up, but try and avoid applying anything like talcum powder or deodorant around the breast area because it can affect the imaging. And of course, if you have implants, just make sure to tell the radiographer beforehand so that they can adjust the imaging appropriately. So if you've not been contacted or you've missed your appointment, it's not the end of the world. Don't then just say, okay, I'm going to wait till I'm invited next time. You can actually go on the NHS website, contact your local screening service and get another appointment. If you're not that into going on the internet, that's fine. You can always contact your GP. They'll give you the information as well. Now, I did say that screening for breast cancer is between 50 and 70, but if you did still want ongoing breast cancer screening, you would have to be a bit more proactive with it, contact your local service, and you can still get breast cancer screening every 3 years. And like I said, you might expect your first invitation between the age of 50-53, but if you get to over 53 and you've not had an invite, then raise your hand, contact your local screening service to get that. Now, speaking a bit more about family histories, sometimes people don't really want to talk about medical issues that occur in families, but I think it's really important because that's the way you understand your risk and you're able to help prevent things. So when it comes to breast cancer risk, there are a series of things that would make you at heightened risk, and you can just raise your hand up to your GP and say, actually, I've got a family history of this. I would qualify for more intense screening, such as yearly screening or screening at a younger age. Even as young as 30, if you're at risk, you can get access to breast cancer screening. So this includes people who have first-degree relatives that have had breast cancer in a female under the age of 40. If you've had any male relative that has had breast cancer, it is possible. It's a small risk, but it's a small proportion of the breast cancers, but it's still possible that you can have a male relative with breast cancer. Or if you have a relative that has had both breasts affected, if you have multiple relatives that have had breast cancer, so 2 or more essentially, or if you have over 2 relatives on your male side, you're at increased risk as well. Anybody in your family under the age of 45 that's had a sarcoma, which is a form of bone or muscle cancer, a brain cancer, or you've had someone in your family with cancers at a young age, also being of Jewish ancestry, or having a family history of ovarian cancer as well. So it's just really important to know your family history and know the conditions that have been experienced, so you know your risk. So essentially, when you get your results, you usually get them by letter in about between 2 or 3 weeks after you've had the scan. You might be invited for a repeat scan if the original one wasn't clear and they need more views. If, for example, they find something abnormal, you might be invited for further tests. So it's between 4 out of 100 women or so will be invited for further tests. If there's something of concern, sometimes you might be invited to a clinic for examination. You might be invited for more magnified mammogram, or they might invite you for an ultrasound scan, at which point they might take a sample of the tissue just to make sure that they're sure of the potential diagnosis. Okay, but do not wait for your screening letter if you have symptoms of breast cancer, because you just need to have that seen right away. And don't feel reassured that, oh, I feel something abnormal, but I've just had a normal mammogram, everything is okay. Like, you know your body. If something is unusual, see your GP. So self-examination is really important. There is no, right way to do it. There's no wrong way to do it. It's just all about you knowing yourself, knowing your body, how it looks, how it feels. So you'd be examining the breast and examining the armpits as well, right up to the collarbones. So you could do it in the shower, lying down in bed, anything that works for you, as long as you know what your body is like. So these are some of the symptoms of breast cancer. So like if you notice a thickened area of the breast, if you notice any dimpling or any like crusting around the nipple, if you find that you've got like areas that are red and hot. Of course, if you're a breastfeeding woman, you might think it's an infection, but if that's not you, don't just put it down to something that will settle down. That could be a symptom. If you're having fluid coming out of a nipple and you're not breastfeeding, that's unusual. If you're noticing like sores that are not healing, if you're noticing any new bumps, any veins that are starting to get bigger that you didn't notice before, if your nipple's changing shape, if it's sort of becoming sunken, if you're noticing that the shape of your breasts are changing, one is looking a lot bigger than it used to be, or if the skin texture is changing, if it's sort of looking like orange peel, or of course if you notice any lumps. Those are all unusual things. Even if you're not sure, even if it's breast pain, that's fine. If you're not sure, it's better to have it checked than just to self-reassure. Now we're going to come on to cervical cancer screening. So the cervix sits at the opening of the womb towards the end of the vagina. It's sort of donut-shaped, if you think of it like that. I don't want you to associate with donuts, but that's okay. It's the 4th most common cancer in females in the UK. Around 3,400 or so women are diagnosed with cervical cancer each year, and it's most common in younger women as compared to breast cancer. It's more so around the age of 30 to 34. Essentially, cervical cancer screening is a little bit different. It's more so to pick up on abnormalities that might lead to cervical cancer, rather than diagnosing cervical cancer. But in the process of being assessed for this, cervical cancers can also be found. Essentially, it's a smear test where it's a soft plastic brush that is rotated at the opening of the cervix to collect cells. These samples are essentially checked for HPV. HPV is human papillomavirus, is a very common virus that can predispose and can put people at risk of cervical cancer. But of course, HPV is also a virus that can cause things like warts that don't lead to cancer. HPV is spread by sexual activity. Any skin-to-skin contact to the genital area is how it's essentially spread. Most HPV, to be honest, does settle on its own. Even if somebody has HPV on one smear, they could go to their next smear and it's absolutely negative. But in some cases, it can lead to cervical cancer, which is why it's tested for. So who is invited? All women who have a cervix, who are aged 25 to 64. You might get your first smear invitation maybe 6 months before you turn 25. So between the ages of 25 and 49, you're invited every 3 years. But of course, as you get older, the risk is not as much, so the screening reduces. Above the age of 50 to 64, it's every 5 years. If you're over the age of 65, screening might stop, but it might continue, for example, if one of the 3 previous tests that you've had before have been abnormal. If you've never had cervical screening, you can get one over the age of 65. Or if you've not had one since the age of 50. It's a similar way. You're invited by letter, and you'd basically contact your GP to book an appointment to have your smear done. Of course, if you've had a total hysterectomy where they've removed the uterus, you don't have a cervix, just making sure if you've had all of it removed, then you don't need to have a smear. There are reasons why you might postpone your smear. So for example, if you're pregnant, if you've had a termination or a miscarriage, you need to wait 12 weeks until you have it. But there are some cases in which where you've had abnormalities before and you're pregnant, discuss it with your midwife, because it might mean that you might need some other tests to essentially just check that things are okay. Also postpone it if you're on your period or 2 days before or after. Also to avoid having it done if you're on treatment for a pelvic infection, for example, or if you're having any abnormal discharge, so best to just wait. So the results that you'd get, either the sample is inadequate. If they don't get enough of the tissue that's needed, then you might need a repeat smear. It might come back, hopefully it comes back normal, and you have no signs of high-risk HPV, and then you continue on your normal screening interval for your age. If you have been found to have high-risk HPV, they then decide to have a look at the cells and see if there are any abnormal cells. If there are no abnormal cells, you have a repeat smear in a year. If by the second repeat it's still positive, then you're referred for another test called a colposcopy. So you can see in the picture where they basically look at the cervix directly with a magnifier, so they're able to have a look and see for abnormal cells. They also might put some chemicals on the cervix to sort of see if they highlight abnormal cells. If so, then they might take a biopsy to sort of check and see if there's anything unusual. Then a similar thing, if you're high-risk HPV, abnormal cells, they do further tests. But of course, if your colposcopy shows no abnormal cells, then they repeat a smear in a year. But if there are either precancerous or cancer cells, they treat it, and then they'd monitor accordingly. Okay, but the same thing, don't wait for screening. If you have symptoms, see your GP. Even if you've just had a normal smear, it doesn't matter. Just go and talk to someone about it. So some of the abnormal symptoms to look out for, if you're having persistent and unexplained, like abnormal bleeding, so meaning bleeding between your periods, bleeding with or after intercourse, if you're having any unpleasant vaginal discharge that isn't down to infection, if you're having persistent pelvic pain or pain during intercourse, it's important to go and have a check and discuss with your GP to have your cervix examined and to rule out any other causes as well. Okay, and just to remind you, if you have symptoms, just go see your GP, have it looked at. Okay, thank you.
Thank you so much. Now we'll have Nutritionist, Nicola Burgher. Welcome back. I remember the last time. It's good to have you. God bless you.
Hi everyone, I have to put these on, I can't see. It's a pleasure to be back. In fact, I think they're very focal, so I'll put them here till I'm speaking and reading. But yeah, really pleasure to be back today. And what I've been asked to talk to you about is supporting your bone health after the menopause, and also bowel cancer, so reducing the risk of bowel cancer. So in fact, while the slides uploading, I'll tell you a little bit about myself. So for those of you who haven't met me, my name is Nicola Burgher Kennedy, and I am a registered public health nutritionist. I used to work in the food industry, but as I was talking to some of the doctors today, I was saying that my passion was really to, I guess, encourage and speak with individuals about their health. And so currently I work with the NHS Diabetes Prevention Programme for those people who are pre-diabetic to, I guess, ensure that their diet means that they don't progress to type 2 diabetes. So that's where I currently work now. And it is a very rewarding role. That's fine. Okay, I'll do it slightly differently, but I'm sure you understand. So my topic today is food as medicine. And like I said, I'm going to be talking about bone health, so how you can protect your bone health after the menopause, and also about how you can reduce your risk of bowel cancer. So you can't see the diagrams, but the first slide I wanted to show you was around the Eat Well guide. And if you come to the workshops, you'll be able to see it. But the Eat Well guide is basically the government's diagrammatic representation of what a healthy, balanced diet should look like. And it's the basis of my talk today because eating the Eat Well guide way allows you to support your health, and it also allows you to reduce your risk of certain diseases. That includes things like osteoporosis, osteomalacia, osteopenia, so that's bone health issues, and also to reduce your risk of bowel cancer. So today it's not so much about wondering what nutrients specifically, but what I want to encourage you all to do is to really eat a healthy, balanced diet. And just as a recap, that means 5 portions of fruit and veg a day. And as I'm going through, if you can just think to yourselves, am I currently eating this? Because if you start eating this way, you already reduce your risk of diabetes, various diseases, and support your health. And I really believe that's what our Father wants us in heaven. I believe that's really what he wants us to do, to live an effective, healthy life. So it includes 5 portions of fruit and veg a day, at least. So if you're not there, just really think about that and how you can improve. The second thing is eating whole grain products as well. So our food should be based on whole grain products. So that's whole grain like rice, whole grain pasta, whole grain bread, rather than the refined. And just having a portion of that at your meal times as well. The other thing we should be doing is reducing our consumption of red and processed meat. That's really important, as we'll see when it comes to bowel cancer. And increasing our protein intake from sustainable sources like pulses, soya foods, for example. So soya beans, pulses, peas, lentils, things like that. We really should be increasing our protein intake from that. And the other area we should be looking at is our calcium, which is so important, so the dairy side, and that's so important when it comes to reducing our risk or supporting bone health after the menopause. Other things we should be looking at is reducing our consumption of the things, I won't even quote them because we know what they are, that we should be eating less of. So we really should be looking to have that once or twice a week at the max, the foods that we know are less healthy. Reducing our fat intake so that we're really having more of the healthy fats, the unsaturated fats and oils, ensuring, especially in weather like this today, that we're having 6 to 8 glasses, 1.5 to 2 litres of water every day, at least, just to keep our body rehydrated. And those are the top line things that a healthy, balanced diet, is consists of. Thank you so much. So I wanted to start talking about healthy bones. So let's pop these on. So the key points, a healthy diet, as I've said, it's important for so many things, but it's really important for healthy bones and from an early age as well. Eating healthy from an early age is so important later on, especially when it comes to calcium, but we'll look at that in a second. Healthy diet is the best way to obtain all the nutrients that our body needs, including the bone healthy nutrients. Again, we'll look at in a second. When it comes to bone healthy nutrients, we're talking about things like, specifically, I'll focus today on calcium and vitamin D, along with other bone nutrients like protein, magnesium, and phosphorus, all of which you can get from a healthy, balanced diet. Physical activity, as Dr. Cheryl alluded to, it's so important for bone health as well, to really encourage you to do the 150 minutes a week. That can be broken down into 30-minute segments for 5 days a week, or however you want, but just to ensure that helps with bone strength and it helps with bone density as well. All of the absence of the above can increase our risk of bone disease in children, rickets, and in adults, osteoporosis. Next slide, please. I just wanted to list here, and again, please do have a look and see, am I eating these foods when it comes to healthy bones? Are they even incorporated into my diet? So on the left-hand side, your left, those will be the calcium-rich foods. So you've got dairy products like milk and cheese and yogurt. Are you eating enough of that? Green leafy vegetables if you're a vegetarian, or a vegan, like broccoli, cabbage, okra, not necessarily spinach. Soya beans, as we spoke about today, edamame beans, pulses, tofu, calcium set. Plant-based drinks, which are calcium fortified. Nuts, sesame seeds. Are those included in our diets? Bread, in the UK, bread is fortified with calcium. Is that included in our diet? And preferably whole grain, even though refined bread, like white bread, is fortified as well with calcium. Fish, where the bones are eaten, like sardines and pilchards, are we including those in our diets? Are we getting the 2 portions of fish a week, one of which should be oily? Dried fruits like raisins and apricots and figs, do we include those in our diets? A handful of those is 1 portion. These are the foods that contain calcium. On the left side, or your right, sorry, is sunlight for vitamin D. The majority of our vitamin D comes from sunlight, so it's so important today even to get out less or whiter, lighter skin, 10 minutes at least. Darker skin, approximately 30 to 40 minutes daily, just to get that vitamin D. And it's funny because majority of us darker skinned live in the sun, or majority of us are from the sun, let's put it that way. And so we would naturally be getting that vitamin D anyway. But if we're not, it's important when the sun is out, get some sun. Oily fish, are we including that in our diet? Sardines, mackerel, salmon, are those foods in our diet? Eggs, the egg yolk, red meat, liver, fortified fats and spreads, breakfast cereals that are fortified with calcium, or vitamin D. Plant-based drinks as well, and of course supplements. Next slide, please. So menopause and bone health, Dr. Cheryl already alluded to. Bone mass peaks at round about the age of 30 in all of us. And so it's really important. And when I say bone mass peaks, that's between 0 and 30 is the best time to get as much calcium into your diet as you can. That's when it peaks. From the age of about 35, we're looking at a steady decline in calcium. Estrogen, as Dr. Cheryl already said, estrogen is responsible for really supporting and being protective of bone health. And as the menopause starts, we're already losing it from the age of 35 anyway, slow decline. As the menopause starts, then we start to see a rapid decline in estrogen levels, which means, in effect, that the bone is being less protected. HRT, already mentioned, can support estrogen levels, which then, in a sense, helps to support healthy bones. But as discussed, there can be risks to this, or potentially some patients or people cannot take HRT. So dietary means is another avenue that we can look at. Next slide, please. So what can I do? What can we do if we're postmenopausal and we want to protect our bone health? So yes, it is possible, and I've just listed a few ways that we can incorporate practically how to support our bone and reduce the rate of bone loss. So first, aim for 3 portions of dairy a day. 2 to 3 portions of dairy provide approximately 700 milligrams per day of calcium. Really important, that's the recommendations. If you are dairy intolerant or allergies and you prefer dairy alternatives, again, 2 to 3 portions of dairy alternatives, as we mentioned in the previous slide, the sources. Consume vitamin D-rich foods, so oily fish, 2 portions of fish a week, and all the foods, and also try and get some sunshine. Expose your skin to sunshine, and that means direct sunshine rather than using sunscreen, clearly being very careful of too much exposure to sun. Certain groups are encouraged to take a vitamin D supplement. So darker skinned, if you're elderly, if you're housebound, if you're covered up, for example, those people, please take I would encourage, in fact, the government encourages certain people all year round, and certain people just between March and September, April, September, not in that time, because that's when the sun's shining, so outside of those times to take a supplement. Moderate exercise, so weight-bearing, strengthening exercises that we've spoken about. So try and get out walking. Simple things. It doesn't have to be the gym, weightlifting. It could just be carrying bags, literally shopping bags. Most of the time, we were discussing earlier, everything's done online now. Nobody's really going out. Just love the online. Oh, poop, poop, and there it is. The van comes up, and that's our exercise to go to the van. Well, we don't even go to the van. In fact, the van comes to our door. In fact, we do nothing. So basically, it's important to try and really incorporate it into our lives. It's recommended 2 times a week with weight-bearing activity and strengthening, and 150 minutes per week of cardio, so walking. Really helps the bones. Okay, so this is a big one. Maintaining a body mass index, so a BMI, body mass index of between 19 and 25. So the majority of us have, so basically between 19 and 25 is a healthy weight. Anything over 25 is either overweight or obese, and anything under is underweight. We can maintain a healthy body mass index, then we are supporting our bone health as well. And then supplementation. If you do take supplementation or you're intending to, then just speak to your GP, especially if you're on medication. Okay, I really just wanted to touch briefly on plant estrogens. There's been a lot of talk about plant estrogens, and does it make men have breasts, and does it turn men into women, and lots of things like that, all of these myths and wonderful things. But basically, plant estrogens, I believe they're in the diet for a reason. God has made them and they're there. So there must be a purpose to them, because everything he does is purposeful. He's an intentional God. So we have compounds in plants called estrogens, and they're very similar to the human estrogen that Dr. Cheryl was just alluding to. And if eaten regularly, these foods in sufficient amounts can have mild estrogenic effects, and I think that's amazing. I'm just like in awe of God, to be honest, but I think it's amazing. So they may also, there's research to show that these plant estrogens, so food compounds that act like human estrogen, there's evidence that they can, in fact, support bone health. It's an ongoing area of research, but there is more research needed, but there is evidence that points to these products or these compounds actually having protective effects on our bone. In some women as well, it's not just bone, as Cheryl said, Dr. Cheryl said, sometimes it's the symptoms of the menopause that they can help with. But because they're food and they're not medication and they're not in therapeutic doses, it can take some time to work. But I would encourage you to include these foods in your diet if you're thinking of wanting to support bone health, and just generally as well. Plant estrogens are wonderful compounds. They're better for some women than others, and it's better if you consume them over time rather than just taking one big lump of, dose of, a load of soya milk. Just have it as part of your healthy, balanced diet. And sources of plant estrogens, just some of them include soya products, edamame beans, which are raw soya beans, basically, pulses, also grains, whole grains, all the foods I mentioned previously, all have plant estrogens in them, and it's really good to incorporate them into your diet. The majority of research has been done in soya, but that nonetheless, please, if you can incorporate them into your diet, that will help with bone health. Next slide, please. So, moving on very quickly, got a couple of slides on reducing your risk of bowel cancer. So, we've discussed what a healthy balanced diet is, and a healthy balanced diet, again, if you're consuming it, can reduce your risk of certain cancers. A healthy weight between 19 and 25, your BMI, can reduce your risk of bowel cancer plus 12 others. So if you just look at your weight alone, if that's the one thing today, like, okay, I'm going to sort my weight out, or I'm going to do this, you're already reducing your risk of many cancers, including bowel. Cut down on processed food and red meat, because these have been shown to increase our risk of bowel cancer, and currently we're eating quite a bit. People who eat a lot of red meat and a lot of processed meat, salami, sausages, bacon, all of those kind of meats, have been encouraged by the government to cut down to 70 grams a day. And I'm a very practical nutritionist. So 70 grams a day would potentially mean on a plate, if you cut ham in 3 slices, very thin, not thick. So if you cut them in 3 thin slices, about the size of half a slice of bread, you're looking at about 70 grams on your plate. And not a lot, but this is the recommendation, 70 grams a day. High fiber foods, so the whole grains, as I was talking about before, very important for reducing your risk of bowel cancer. And weirdly as well, research has shown that dairy can reduce your risk of consuming dairy products, not dairy alternatives yet, but dairy, and it's thought the calcium in dairy is doing something there. Again, more research. Fiber helps digestive health, and it also helps maintain a healthy weight because you're less likely to eat between meals. It keeps you fuller for longer, and of course, stable blood sugar levels, so you're not as hungry. Next slide, please. So what can I do? So this is just an example of what you can do to reduce your risk of bowel cancer. We should be consuming 30 grams of fiber a day, and like I said, I'm a practical nutritionist, so 30 grams to some people, what does that mean? It's quite arbitrary. So 30 grams, it could mean switching to whole grain and just having a high fiber cereal, all bran. I'm not here to promote cereals. I've worked for most of them, but I'm still not here to promote them, but all bran, what's another one? Weetabix, oats. These, just have that for breakfast. That's a switch. Could just be one switch you make today. Fruit and veg with every meal, so ensuring that your plate is half full of vegetables. If you're still working to that, then a third of vegetables, but half of your plate should be vegetables, and that's the recommendation, just for health. Eating the skin on veg, so like potatoes, I believe we peel away a lot of the nutrition and throw it in the bin, and then it goes to landfill and just waste. But in these are nutrients. So if you're having a jacket potato, for example, then just try and eat the skin of that with the meal, or carrots even. Can eat the skin on carrots too. Just wash them and cut them up as they are and eat them with the skin, rather than throwing that precious skin away, which has so much nutrition. It's unbelievable. Use pulses and beans in the place of meat. I know it's not always great. We were just talking about the cost of living and how expensive it is now to buy meat or even food. Just add pulses to it, or sweet potatoes. Just this, again, can help reduce your risk of bowel cancer because you're aiming for the 30 grams of fiber a day. And whole grain snacks, so plain popcorn, fruits, nuts, seeds, whole grain crackers, all of these are increasing, it tastes nice too, but increasing your fiber intake, so then you're reducing your risk of bowel cancer. Maintain a healthy weight, we've discussed 19 to 25 BMI if possible, and stay hydrated. Water and fiber and a healthy weight make the triangle for basically reducing your risk of bowel cancer. Next slide, please. So, in summary, a healthy diet and lifestyle is important for reducing your risk of disease overall. Calcium, vitamin D, and protein are important to reduce the rate of bone loss after the menopause. Regular activity, sunshine, remember, 30 to 40 minutes direct on the skin or less. If you're lighter skinned, 10 minutes, very important as well. Phytoestrogens may have a role, so try and include those in your diet. A diet that's high in whole grains and fiber, dairy products, and sufficient hydration can help reduce your risk of bowel cancer. And finally, a healthy BMI, as we've discussed, is not just important for bone health, but it's important to reduce the risk of at least 13 cancers. Okay, thank you.
Thank you so much. We're going to... things have been shifted around because of how things have gone. For the men that are here, you're still men. It's, but we thank God for what we've been hearing. We need to know. It's the kind of thing that sometimes men, we look for the back door to get out. But it's all about life, isn't it? So what we're going to do is have Danielle Scott will come, and then we're going to have a break, and we have our two male doctors that are here. So men, don't run away during the break. Yeah, this is really, really important. It's wonderful that we can be doing this again today. And we want to thank you again for giving your time and volunteering doing this. It's so important that we know about these things, and we're not here trying to bury our head in the sand. I heard someone make the statement the other day about the ostrich, how she buries her head in the sand, like to get away from things, and it's total nonsense. She puts her head in the sand because that's where the eggs are. She's actually looking out for her eggs. Sometimes we can just reverse things, isn't it? So let's welcome Danielle as she comes right now.
Hello everyone, very warm, remember to keep hydrated. So I'm Dr. Danielle Scott and I'm an chartered educational psychologist. I primarily work with children, young people from nursery age up to the age of 25. So what I'm going to do today is recap on what is mental health. Obviously I did an introduction in February, but we're going to go over some details again. So like physical health, we all have mental health, and this includes children and adults. So it's about maintaining our mental health across the board. And mental health incorporates our cognitive, that's our thinking skills, our behaviour and our emotional well-being. It's normal, you've got to contextualise, for sometimes to feel a bit sad, a bit down, a bit low mood. But if that increases or worsens in time, then it could be developing into kind of mental illness, mental health conditions. Our mental health can be compromised at certain points in our life, also due to social circumstances, economic, environmental. So there is research that shows that a risk factor could be living in poverty, for example, deprivation, being in a hostile environment, bullying, being subject to some sort of abuse. So mental illness, conditions, disorders, whatever terminology you prefer to use, is when your emotions, your thinking, your behaviour is affected to the extent that it's affecting your daily functioning. So that means that you're not coping in the home, you're not able to keep your house clean, tidy. You might see that with some of the young people, that's, you know, obviously some young people don't like to be tidy anyway, but if it's going on to an extent where you can't see the floor at all and you're concerned about their personal hygiene, it could be going on to a different level of mental difficulties. That functioning also could be that you're not able to go to work, you're not functioning in any capacity in your daily life. Okay, we've also seen an increase in mental health or mental illness. It's more recorded now in men. So we're finding that men are 3 times more likely than women to die by suicide. Men aged 40 to 49 have the highest suicide rates in the UK. Men report lower levels of satisfaction than women, and that's sometimes linked to work or other things that they've kind of hoped to kind of reach, and they haven't. Men are less likely to talk about their emotions or feelings and less likely than women to engage in psychological therapies. Men are more likely to act out their feelings or emotions via anger, disruptive or antisocial behaviour. So that could be more the ways that they're kind of showing that actually something more is going on. In terms of women's mental health, around 1 in 5 women, so if you think of the women sitting in the congregation, 5 women, 1 in 5 of you sitting in the congregation could potentially be affected by depression or anxiety. And the possible reasons for this is that women are more likely to be carers for their parents, for example, carers to their children, which can lead to stress, anxiety and isolation because you're not able to socialise in the way that you would have done as a single person, for example. More likely to live in poverty, particularly single mothers that might be on lower income bracket. They work mostly from home, particularly after the pandemic. That is also showing an increase in that isolation, and some women are kind of suggesting that they're finding that isolation is causing mental health concerns as well. They're more likely to experience sexual violence, which can lead to post-traumatic stress disorder, also abuse or domestic violence within the marital home. When women find it difficult to talk about these emotions and feelings or situations that are happening, that can also lead to depression, eating disorders, or self-harm. Women go through different life events, life changes, so that's also at the teenage stage. So we find by year 9, we start to see the onset of mental health difficulties in schools, and we try to get in with the early intervention. Also prenatal and postnatal depression, and as Cheryl talks about menopause, also some of the mental health concerns can come up around that stage as well. In terms of children and young people, so if you think of the family structure, if men are being affected, then women are being affected. These are the people that we're working with in the workplace, but also these are the family structure, so then the children are being impacted. So we're finding an increase in mental health difficulties in children. There's an increase in depression, self-harming, particularly children. I specialise with children who are in the care system. So we're finding that there's an increase in self-harming because they've got going through that internal turmoil. They are pinching, scratching, pinching their skin. Some of the children I've worked with, they're plucking hair out, individually plucking out hair of their eyebrows, their scalp, eyelashes, until there's no visible hair. Swallowing sharp objects. It's progressing. We're finding there's a real increase in generalised anxiety. Unfortunately, it's not just the children, it's the adults as well. So we're having anxiety across staff in the school system. We had increase in anxiety of staff going back into the workplaces after COVID. And then we're seeing the anxiety obviously playing out with the children as well. Also an increase in difficulties or diagnoses in ADHD, autism spectrum disorder, and eating disorders, particularly if children are in an environment where they feel under a lot of pressure or they've been abused in some way. The only thing they might feel that they can control is what they eat and how they eat. So with all this increase in mental health that we described, unfortunately, the mental health services are struggling. We are understaffed across all boroughs, so there's a national shortage in psychologists and psychiatrists and professionals in mental health services. We've tried to create different posts to kind of encourage those who might not have doctorate level training to come in and kind of support the mental health increase by creating posts within schools like mental health school teams. We're now creating assistant psychologist posts because we don't have enough. We're now recruiting psychologists from abroad, but that presents other difficulties because they don't know the cultural norms of our culture. So today what I would like to offer in the workshop is solution circles, where it's groups of 9 adults together to show you principles of positive psychology, that as a community that we can come together and support one another when we're going through difficulties by a framework that we can use, because we cannot rely on just the system, the NHS or the local authority alone. Okay, so please remember, if you've got any questions, please write them on the post-it notes, and then we can stick them on there and we can go through those questions after the break. Thank you for listening. Pray you continue to be blessed today.
Okay, good to see you back. Excuse me. We're just going to welcome now Dr. Danielle, and he'll give us his surname. And then following Dr. Danielle will be Dr. Joshua will follow Dr. Danielle. Let's welcome him as he comes. Thank you.
All right. After lunch, how are we all feeling? All right. It's good to be back, and a lot of familiar faces in the audience. My task is to talk to you about general health. So it will be a good overlap across the family settings, really, if you like. Okay, so I'm Danielle Abioye. I'm a general physician and heart specialist. And so I'm going to be talking to you about health prevention. So it's better for you to stay healthy, because once you become unhealthy, then you have to visit the doctors, and one thing leads to the other. So hopefully we can keep you healthy. And if you have an illness already, you can manage that in a way that you can remain healthy with you minimizing the complications. So primary prevention is interfering before you become unwell. Secondary prevention, you've got a problem how you can manage it at its early stages, and the tertiary prevention is now you've got the disease and the disease is causing trouble. What I want to show you with this, actually, that the healthcare is only able to help you with 10% of health issues. That's the tip of the iceberg. So a lot of it are actually what you can do something about. The social circumstances combined with the behavioral pattern that take at least 2/3 of health issues. Sadly, you can't choose what family you come out from, and those are the other third of the genetic component. So your health really is in your hands rather than the hands of the healthcare practitioner. All right, what are the things that sort of put us at disadvantage in health? Coming from minor ethnic background put you at disadvantage. You know that the black lady is more likely to die in pregnancy and pregnancy-related problems, for instance. Gender, being a man is bad generally, except if you've got atrial fibrillation, which is one of the leading causes of stroke. That's when you don't want to be a female. But if you're going to choose a gender, it's probably best to be a female, I think. I'm thankful to God for making me a man. Just to put that one out there, okay? I didn't see that one coming. Having one form of disabilities or the other put you at risk of having another health challenge. Coming from a low socio-economical background, we've spoken about the nutrition, which carries a large percentage of how well we can be. You know what I mean? If you're going to buy a piece of an orange, it's much more cheaper just for you to go for the cookies, right? So, and if you're going to buy a good quality brand, as Nikki was saying, eat the oatmeal, why would you go to the oatmeal? It costs, triple the cost. So it's easy for you just to go for the cheaper option. And when you do that, it puts your health in more risk. Those who live in care home, the homeless, and those who live in the who are inmates. Those are the sort of things that put you at a disadvantage. So at the top of that, you see the level 1 to level 10. Level 10 in the social gradient are those who are the richest. And you will see that compared to those who are the poorest, they live at least another 15 years longer. Not only do the richest live 15 years longer, they live in better health longer as well. So, you talking to your teenagers about, making the best use of their time now so they can put themselves in a good stead in life matters most. So, what can we do to promote your health? I've got a list there. I won't repeat what other people have spoken about. So let's go through them one after the other. Strong foundation. Your choice to, become married to someone, the sort of checks that, you're expected to do even before you decide to become pregnant. In the room, there would be sickle cell trait. And if you're unaware of that, and then you have a child with someone with another sickle cell trait, you have that 25% chance of giving birth to a child with sickle cell. And like we said, if you are born with a disability, that only complicates the matters at times. It goes on. Somebody who lives with sickle cell disease, for instance, your life expectancy is at least 40 years. Lower than what the average life expectancy is. So having that optimal foundation is so important. Taking those pregnant care, especially planned pregnancy, is better than teenage pregnancy. I think that's self-explanatory, because overall it put that child at a health disadvantage in the longer time. Raising children in healthy home. And I realized that nowadays, we talk about instant family, right? whatever the family is designed by the people involved. But you're thinking about raising those young people in a healthy environment is important for their overall well-being. Oral health. I realized that, up to 1 in 5 children who are less than 5 within the United Kingdom have dental problems. I'm talking about the United Kingdom. When I came across that data, I couldn't believe it. And it's something that you can easily overlook, isn't it? So the decision to take them to the dentist has to start from when they start teething. Some of us are now 40, we still haven't been. Safer community. Living in London, as you know, is one of the dangerous places you can live within the United Kingdom. As you veer outside, it just generally becomes safer, and that goes also with better health. We talk about environmental pollution is part of the choices you can make. In London, as one of the higher rates of the environmental pollution, the reason why the ULEZ is being introduced. Okay, so if you are raising your children in an environment with dirty air, right, they're more likely to suffer from breathing problems like asthma, etc. Connected communities. And I think as those of us who are people of color, it's probably one of the stronger heritage that we have. We stay connected, yes? And it's important that you don't allow, family feud get in the way of that child building bond with their aunties, their uncles, and their grandparents. The moment you seclude and isolate them, you put their health at risk. And it's so beautiful to see when the Caucasians support themselves as well, especially those of us who work in the hospital. You see that, the Caucasians stand as advocates for their family members. This is what we should be doing for one another as well, even from young age. Immunizations. Many theories, etc., especially with the COVID, autism. Put simply, take it. All right, so obesity is not only a problem of the old, the children as well. Again, you can see 1 in 4 children in reception age are overweight or obese. And if that is the foundation that they start with, it lingers. So again, watching what they eat. It's easy just to let them eat yogurt all day long because now they're quiet, they're not going to trouble you. But be mindful of that. 1 to 3 who are year 6, in year 6 are again overweight and obese. And when you start talking about adults, 2 in 3 of us are overweight. And of course, being overweight comes with its own health complications. So eating well, exercising, keeping your weight down is, utmost important. Staying active, I think we've already spoken about exercise this afternoon. Again, exercise, can help manage a lot of your chronic conditions like hypertension, diabetes, and osteoarthritis. The list continues. And in fact, there's some more recent data that suggests that those who are chronic long-term smokers and who are exercising are healthier than those who are non-smokers without exercise. Are you with me? I'm not saying pick up the cigarette. I'm encouraging you to pick up the exercise. Get out of the house, do the walk 5 times a week, right? Important. Sleeping well. This is a personal note, by the way. Sleep well. Especially in the youthful age, because you think you can do everything. Some of us, especially those of us who are migrants, we often have 2 or 3 jobs together. Some people don't get to rest for the next 24 hours, etc. It has implication on your memory. There's a protein within the brain called tau. Some of you are medical, you know what I'm talking about. That protein, it's what passes information within your brain neurons. When you sleep, the information overload gets deleted, so you can make new memories. But when you are depriving yourself of sleep, the process that prunes the brain that allows the brain to self-renews, that process is hindered. And when that continues, it becomes a case whereby information connection within the brain is hindered. When you're younger, you may not realize, but when you're older, it has a toll. So in fact, you know that, especially for men, those men who get like, I know I'm on the men's side, like I said in the beginning. So it's good for men in particular, also for ladies, but more importantly for men, to actually get like 10, 15 minutes nap a day. Those people who do that, they are healthier. Not only that, they have better memories. And I think you'll agree with me. You don't need a research to prove that. When you've slept well, you can relate better. Your brain works better. But when you've been, going from one job to another, it doesn't work so well. So, to avoid dementia, have a good sleeping pattern. Avoiding stress. Again, as a bit of getting healthy overall. Because a lot of you spend a lot of money on buying the good food and building connections, but there are certain situations that you can avoid in life. That's stress. Again, recent data shows that stress does cut short your DNA. Your DNA is your ability to replicate and grow. So the shorter your DNA, the closer you are to entering the grave. So meaning when you're younger, you come with a long DNA, and then that replicates over many years. And as time goes on, it reduces. And then that's what happens as people get into the advanced age. But stress thus has the ability to make your DNA get even shorter and shorter. I think you know what I'm talking about, right? So avoid stress. In fact, Proverbs 27:11 says, a cheerful heart is good medicine, but a haughty spirit is osteoporosis. That's my interpretation. Yeah. A broken spirit dries up the bone. Yeah, see, she knows what I mean. Okay, so avoiding stress, very important. Some people, in the bit of getting involved in unnecessary stress, people get heart attacks as a result. People get a stroke as a result of having an argument. Sadly, there are stress you may not be able to avoid, such as losing a family member. Again, that can have its toll on your health. It can give you what they call broken heart syndrome. It's very well documented. So stress in any case, do your best to avoid it, not only in the short term, overall in the long time is what is good for your health. Okay, so I thought I'd put this one in as well in the bid of us staying healthy. Especially in the world that we live now, everything is becoming digitalized. The technology is advancing. And in fact, it's shocking to see that some of us who are even young, we relate with technology in the way that we would like to, but when it comes to the health aspect of things, it's something we overlook. So surely if, the 70, 80-year-old can be taught to use these advanced technologies in order to better their health, those of us who are younger in our middle age, we can learn as well. So artificial intelligence, doesn't have to stand as advanced as it looks. It's simple things like you checking your own blood pressure at home, you checking your own blood sugars at home, calling in to the doctors or to the nurse so they can give you advice on what to do about it. So it's important that you engage in this way. Wearable devices, I see some people have, the Apple Fitbit, and it doesn't have to be that brand that's so expensive. Again, cheaper brands can actually detect things that can be life-transforming. I mentioned atrial fibrillation earlier on. 1 in 4 of us will suffer it if we live long enough. And it can be a silent condition as well, like hypertension, that you don't know you have it. And in fact, most people will diagnose it when they've come in because they've had a stroke. It's the leading cause of stroke, and yet it often goes undiagnosed because people may not experience it. But, just investing in a Fitbit can actually prompt you to seeking help from the doctors. The genomics is coming as well, whereby they ask you, let's take a sample of your saliva, and we can, process your DNA and all that stuff, right? It can help improve your own personal health and also the health of the people around you, okay? I say that knowing that we're in a religious setting, some of us may have diverse, opinion about, them coding 666 into your DNA and all that stuff. All right. As Pastor said, it is the will of God that we will be well, that everything will prosper with us, okay? Sadly, you might be related to someone, or somebody who's just, it's not normal for someone to drop dead, playing football. But you hear it all the time, don't you? All right, when that happens, it is needed that the first-degree relative at least are screened for heart condition. So if you get that letter through the post and say, because of, Uncle X who died 5 years, 10 years ago, it can take that long for the letter to come through. Don't just ignore it. So for your own benefit, please do engage in these things. Active co-health partners, like I said earlier on, how much of your health is down to the doctor? Yes, mission accomplished. So being an active co-health partner, you prompting your doctors to do what they need to do. And I say that knowing what the situation of the NHS is now, especially with the GP. If you're waiting for the GP to send you the screening letter, they will, but it may take them a little longer because everything is in the backlog. More important letters, they haven't even actioned it. I'm telling you this as an insider, Please do not take offense as GPs. So please be the person in the driving seat of your own health. If you know you do something, don't be avoiding it. Show up. Engage with your healthcare practitioners. Okay, I think that's really what I want to talk to you about. So that's the conclusion. So people take good health for granted until we, advance in age or we suffer a major health condition is when we start taking our health seriously. Now that you're healthy, it's better for you to engage in those primary prevention that we've been talking about all morning. Health is a shared responsibilities. I think you get that message. And good health is the foundation of happy families, thriving communities, and strong economy. God bless you and thank you for listening.
My slide isn't a PowerPoint, so I hope that I can progress through it well. Let's just see. It's a bit different. Okay. Works. Okay, that's good. My name is Joshua Fasuyi. I'm a plastic surgery doctor at Norfolk and Norwich. Thank you for having me today. I know Cheryl from university, and I know some of the other guys from university, and I was here last year as well. So it's nice to see everybody again. I'm going to talk to you briefly about health screening for men. I have given a little something to be passed around, and it's just for a bit of the talk a bit later, just so you know a bit of the anatomy, mostly about the prostate and then the testes. So, content-wise, we're going to talk about what screening is available for men in the UK, and we're going to also talk about, with that, we're going to talk about bowel cancer and abdominal aortic aneurysm screening. We're going to talk about things to look out for these conditions, and we're going to talk about the relevant anatomy behind that. Lastly, I want to talk about testicular and prostate cancer. These aren't part of the routine screening programs, but it's important to talk about that as men and also important to talk about that as particularly Black Afro-Caribbean men because we're at higher risk of prostate cancer. So why all the fuss about screening? So screening is really important because it helps us to identify risk individuals who have these conditions so we can treat them earlier. We all know that prevention is better than cure, and we want to treat as early as possible so we can have a more successful treatment. Bowel cancer. So you probably recognize this gentleman, Chadwick Boseman. He's an actor. He did Black Panther, he did a few other movies as well, and throughout 2018 he was diagnosed stage 3 colon cancer, and he sadly passed away 2020 with colon cancer stage 4. And he went through multiple surgeries, chemotherapy throughout his movies and the productions that he did. So bowel cancer accounts for 4%, is the fourth most common cancer in the UK. I keep looking up here because I can look there, but actually my eyesight is not that good. It accounts for 11% of total cancers, we can see there. And just going back to some stats, for men, it's the third most common cancer. So the cancer survival is actually improving. It's been improving over the last 40 years. And we know that if it's diagnosed early, that more than 90% of cancer cases can be treated successfully. So it's worth going through the screen, and it's worth identifying early because there's a good way to avoid problems with that. So looking at risk factors, so there are several risk factors. It's multifactorial, and essentially age is the biggest factor. It goes down to the changes in the DNA of our body. So we have DNA in every cell of our body, and if the DNA is broken in any way, then it can predispose to cancer. So as we age, there are more chances of the DNA being broken in that way, so we can have higher risk of developing cancer. Additionally, there are environmental factors and dietary things that can change the DNA as well. So we always advocate having a high-fiber diet, as alluded to earlier, because low-fiber diet does increase the risk of colon cancer. Alcohol, smoking are all included as well. So actually, with fiber, eating too little fiber accounts to 28% of colorectal cancer. 13% of colorectal cancer is caused by eating processed meat, and 11% of colorectal cancer is caused by being overweight and obese. So these are several preventable health things that we can obviously address to reduce the risk of colorectal cancer. So speaking a bit about the symptoms, so there are many symptoms that one can get. So things we look out for is iron deficiency anemia. So if you go to your GP for a blood test and they say you're iron deficient, it may be that there is a background issue. You have to have further investigations and assessment for that, but that's one of the things that we look out for. Unexplained rectal bleeding. So there's several causes of rectal bleeding, but that's one of the things to look out for as well. Change in bowel habits. So changing your bowel habits from, for example, normal stools to looser stools is a indication to look out for as well. I'm saying all of this with a pinch of salt because it doesn't mean that any time you have a loose stool, it's because you have colorectal cancer. But it's just to say that if you're finding that there are different changes to how your body normally works, it's worth going to the GP for an assessment. So you go to the GP and they'll likely examine you, take a bit of a history about what your symptoms are, and they will likely examine you. And part of that examination is a tummy examination, feeling the abdomen, but also a rectal examination. And I know there's a lot of stigma behind that, particularly for black men, but it's really important that you allow your doctor to help you because these things are preventable. And if you want to live a long and healthy life, it's worth going through the short-term pain, as it were, for long-term gain, okay? So talking about screening. So screening for bowel cancer starts between the ages of, starts at 60, and it's between the ages of 60 to 74, where you're sent a home test kit every 2 years. And essentially, it's the sample. You have to put a sample of poo on the test kit, and you send that back. And that test kit looks for bits of blood in the stool, and that will prompt further investigations if that's abnormal. I did have a video here, and that's from the NHS England website. It's just to say, it gives you information about how to do that. In terms of treatment for bowel cancer, it's surgery, so surgery to cure. There are things that we can do to control the cancer or ease the symptoms. So the second screening that's available for men in the UK is abdominal aortic aneurysm screening. So your abdominal aorta is a vessel in your tummy. It's a circulatory vessel, so it sends oxygenated blood all around the body. And if there's a weakening in the wall of the artery, then this can weaken and start to bulge, which is called an aneurysm. If the wall obviously bulges out, then there's a risk of it bursting open and having internal bleeding. That's called an aneurysm rupture. So that is life-threatening. It's a life-threatening condition. So what we would like to do is to try and catch that early. So that's just an illustration of different places that people can get aneurysms. So it's just telling us that there are vessels, blood vessels that supply the kidneys on both sides of the tummy, and that there is the aneurysm in different areas in relation to that. In terms of statistics, it's prevalent in the population about 1.3%. So if you take 100 people, 1.3 people will have an aneurysm. The prevalence, however, is falling. The prevalence is 6 times lower in women compared to men. So that's a big deal. So men, we have to be really, really mindful of that. In terms of the risk factors, many of the risk factors have been mentioned in the other talks. So fatty changes in the blood vessel can weaken the blood vessel wall and put you at higher risk of this. Family history, so if it runs in the family, there is a genetic component. Smoking, increasing age, and hypertension. Hypertension has a weak association, but you can imagine if you have hypertension and the wall is weak, then it can put one at risk of that. Some of the signs and symptoms to look out for, pulsation in the tummy. So if you're slim, you can feel your tummy, you can feel your abdominal aorta, but if that feels like a big pulsatile and expansile, as in expanding mass, then that's something that you may want your GP to have a look at. Tummy pain that doesn't go away, so non-specific tummy pain, lower back pain, sudden pain in the tummy or back. And then these last 3 are symptoms, really, sort of end-stage symptoms. So when it ruptures, one can bleed into their abdomen, and you can have dizziness, sweating, passing out, or fainting. It's a very high-risk thing, and it's something that I don't think many people are aware of, actually, and I think we need to be more aware of it. So in terms of the screening, it's often not picked up until symptoms, but luckily it can be picked up by screening, which is for men aged 65. It's a one-off ultrasound scan, so a jelly scan which pregnant women get on the tummy to have a look at the size of the artery. So that's kind of just illustrating that in that ultrasound. So it's a painless ultrasound scan. We look at the size of the aorta. So between 3 and 4.4 centimeters across, that's a small AAA. We call it AAA. And that recommends that you have a yearly ultrasound scan as a surveillance to keep an eye on it. If you have a medium-sized one, 4.5 centimeters to 5.4 centimeters, they recommend 3 months follow-up and surveillance. And a large one, 5.5 centimeters or more, is really surgery. You have to look at getting that operated on. And that's by repairing the wall by using sort of a fabric tube supported by metal stents, and we put that in. And I think I've illustrated that in that picture just here. Just here, I don't know if you can work out, there is some tubing, so that's where the stent is. Okay, so that's screening for men. Testicular and prostate cancer aren't part of the screening program, but I just want to just briefly talk about them. So the prostate is, if you've got the thing, you can see that the prostate is there. It's between the penis and the pelvis, and the prostate is really important in helping make semen, which is important in reproduction. It's a walnut-sized gland. It's examined for also via a back passage examination, a lot of stigma around that as well. And prostate cancer actually is one of the most common cancers in men and usually affects men over the age of 65. So 1 in 6, so a few stats here. So 1 in 6 UK males would be diagnosed with prostate cancer in their lifetime, so 1 in 6. It's the most common cancer with 52,000 new cases every year. Incidence rates are highest in males aged 75 to 79, so it affects the older age gentlemen, usually. Each year, around a third of cases, 34%, are new prostate cancer diagnoses. Okay. So this just shows the prostate. I wanted to talk about prostate cancer and benign prostatic hypertrophy. So hypertrophy just means bigger cells, bigger organ, and benign is non-cancerous. So people can develop benign prostatic hypertrophy, which is BPH, and that has similar symptoms to prostate cancer in some ways. It's where the prostate becomes enlarged, and it can affect the way that you urinate and cause symptoms of that nature. So it's quite non-specific, but sometimes the features can cross over, actually, so it's just worth mentioning. This picture over here, you can see that there's a yellow peripheral zone, and that's where the cancer tends to affect the prostate. And in the transitional zone, which is around the tube that you essentially pee from, you can have benign prostatic hypertrophy. So if there are changes there, it can affect the way that one wheezes. But if changes in terms of the prostate cancer happen in the peripheral zone. So risk factors, so being a man, obviously having a prostate is the main risk factor. Age, higher, older gentlemen. Genetics, family history, and ethnicity. So Afro-Caribbean men are at higher risk. So this is why I wanted to talk about this, because there's a lot of stigma behind it. There's a lot of stigma about the assessment. But again, if you want to live a long and happy and healthy life, these are the things that we have to do. We have to go to our doctor and speak about these things. So signs and symptoms, as I said, prostate cancer and benign prostatic hypertrophy, similar symptoms, increased need to pee, straining whilst you pee, and incomplete emptying of the bladder. So some of the symptoms there, obviously it's not all to do with prostate cancer if you have these symptoms, but it's worth going to your GP to discuss them. Assessment-wise, blood tests, examination as I mentioned, MRI scans or biopsies. Talking now about testicular cancer, just rounding up. Testicular cancer is a very rare cancer. It tends to affect younger men now. So the age is 15 to 40. So as young as 15 years old can have testicular cancer. Okay. It's a very rare cancer with 1.5 cases in 100,000 men. So that's how rare it is. In terms of risks, similar risks as I mentioned with the bowel cancer, so changes to the DNA, particularly during development of the testes. So there's a family history can impact and increase the rate of testicular cancer. Abnormal descent of the testes, so as the fetus, the baby is being developed in the womb, the testes drop down into the normal position. And if there's changes there, that can impact the cells that are there and predispose to testicular cancer. And there's other risk factors that I've listed there as well. So in terms of signs and symptoms, the main sign and symptom is lumps that are on the testicles, testicular pain or abdominal pain, and dragging sensation. Assessment-wise, it's examining, so it's being really familiar with self-examination. So I encourage men to do this once to twice monthly in the shower, if you must, just feeling what is normal and feeling for any changes, particularly young men. And that concludes my talk. Thank you. Thanks very much.
We really appreciate Dr. Danielle and Dr. Joshua. I do. I want to thank all of you, really, for giving your time and coming and being with us. And it's one thing for us to hear what's been said, but to apply it is the most important thing. They're going to have a 5-minute water break. So I've been told, a water break. Yes? A 5-minute break, should we say? Okay? God bless you.
So we had a few questions about cervical screening. So one of them, I don't know the prognosis off my head, so I'm going to use Google to help me out here. So one of them was, what is the prognosis if I have cervical cancer? The true answer is, it depends on what stage the cancer is diagnosed, how far it has spread. That will all honestly affect prognosis and survival. But I do have some general statistics on it. So if you're diagnosed with cervical cancer, more than 80 out of every 100 women will survive their cancer for 1 year or more after their diagnosis. More than 60 out of every 100 women will survive their cancer for 5 years after diagnosis, and more than 50 women out of every 100 will survive their cancer for 10 years or more. But these are more general statistics for cervical cancer, but it often very much is dependent on how far the cancer has gone and what stage it is, how far it's spread, to help, decide on the prognosis. And either way, these are all statistics. It's all individual sort of level. Another question was, at what age does one start screening? I think it's about cervical cancer screening, so that's from the age of 25. So if you're 24 and a half, you might get your invitation. And then there was one about, can the contraceptive, I think it means cause abnormal cells when having a smear test? To my knowledge, I don't think so. But of course, there is that small increased risk of cancer, cervical cancer with the contraceptive pill. And after a biopsy is taken, can they get cancers with the next one? There's always that possibility, but of course, the whole purpose of screening is to pick up on changes as early as possible. Treat it right there and then, and of course you'll be monitored quite closely if you've had an abnormal smear before or had, cervical cancer or precancerous cells. So hopefully it would be picked up if there is any abnormality at the frequency of the monitoring, hopefully. And of course, in between times, if you're ever developing symptoms, then you go see your GP to have things seen to sooner. Like I said, I stressed, you don't have to wait for the screening until you sort of mention some of your symptoms, because even women younger than the age of 25, if you have symptoms, you go and see your GP, and looking at the cervix, it looks abnormal, you can be referred for a colposcopy. Even if you're having bleeding or if there's a little bit of redness at the cervix, you can be referred for colposcopy. So if you have symptoms, you can be referred for investigation. And then one was about breast cancer screening. What is an alternative to mammogram? They were concerned about the compression of the breast during the mammogram. I would say try not to be too alarmed by the compressing. It's not a torture device. It's just slightly, pressed together to take the images. And to be honest, for a few seconds of discomfort, if cancer is found, it would be better to have it treated at the earlier stage. So a little bit of compression, you will survive it. It's not going to hurt significantly. It should be okay. Of course, I'm not sure that they would make leeway for an alternative. So that's why I'm kind of stressing to just say it's just a few moments of pressing, and then that's done.
Okay, another question we've got here for the panel. What form of contraception and how, contraceptive question, how does the implant in the arm affect a young person? Can it cause mood swings? Is it safer than IUD or IUS? That's probably for you, Dr. Clarke.
Okay. Good question. The implant's normally staying for a few months. In terms of mood, yes, it can affect the mood. The important thing is to have a good relationship with your GP and let them know whether you are getting on well with the implant or not. It doesn't suit all women. So if you are experiencing unbearable side effects, you don't just suffer it. You go back to the GP, let them know you can have it removed and try another type of contraception. So was there anything else there? When you say safer than IUDs, yes, we could argue it's safer in that there is no risk of perforating the uterus. There is the risk of that with the intrauterine devices. If they're put in a certain way, they can cause womb perforation. And there's also a higher risk of infection with the intrauterine device. So in that sense, yes, it's safer, but I would argue there could be a lot more side effects with the implants.
Thank you. Next question. A man who sleeps throughout the day without exercising, can that also deem as healthy? What would you suggest can be done to help this person? Dr. Danielle.
Right. I did say 10 to 15 minutes during the day. All right. So it's to emphasize the importance of rest, okay? Of course, you can't, a man I'm sure you've got to provide for your family as well. You've got a lot of things going on for you. So you can't really afford to sleep all day either. So sleeping all day is not really an option. That also comes with its own health complication. And in fact, the average hours of sleep should be somewhere around 7 to 8 hours in a 24 hours period on uninterrupted sleep. Anything less than that is related to health complication. Anything more than that also is related to health complication. So it's about getting that 7 to 8 hours in. And like I said, that there's some data coming out to say men who nap during the day, would nap 10 to 15 minutes during the day, they are healthier overall. So sleeping all night is not really an option, I'm afraid.
Okay, this question's more for Nikki. Recommended cereals, what would you recommend? Is Weetabix a no-no?
I'm not really allowed to recommend brands as part of my code of conduct, but basically, like I was saying in the talk, it's all about choosing whole grain where you can. So that's not to say you can't choose cereals that are more refined, I guess, like cornflakes or, I don't know, Cocoa Pops. Those are more sugary, and they can be eaten occasionally, but I'm more talking about more of the time. I would probably, Weetabix is fine. It's a whole grain cereal, like I said, and it gives you an even sugar release throughout, or helps to give you an even sugar release throughout the day. So yes, I wouldn't recommend any cereal per se, because you have own brands as well now. So it's really about looking for that whole grain. And generally it will say on the food label, but like oats is my go-to just because it can be quick and I like it as well. So, and it's healthy. But yeah, basically choose whole grain where you can and more regularly than you would the sweeter, more refined ones.
Someone's also asked Nikki if they could find out about their body mass index today, and what would that entail?
Sure. So as long as you know your height, and we have scales. I've seen some scales. So if you know your height and your weight, then we can work that out. Absolutely.
Okay. In terms of mammograms, Tosin, Dr. Tosin, over 50s, that's every 3 years. You said in your presentation. How far forward can they screen or see in terms of that, with that scanning? So I don't know if you want to clarify.
Thanks, Alan. Yeah, what I'm trying to find out is that you have the mammogram and it's clear, but then you find a lump perhaps a year later. So what I want to know is, because you're assured, aren't you? You think, oh, you're okay, you've had the mammogram, but if you see something else later on, and then of course you've got to go back. So why don't you have the screening every year? I know you've got resource issues and so on, but why 3 years and not every year? Or do you know what I mean?
I don't know the answer to why it is 3 years, but I'm sure they've done some study somewhere. But of course, if the resources were there, we could do a mammogram every year. But of course, you also have to think the more times you're doing the mammogram, the higher radiation exposure as well. So like I stressed, if you have symptoms, go and see your GP, because do not rely on, oh, I've had a normal mammogram. Even if you had a normal mammogram a month ago, if you now have a lump, that's new, and we need to treat that differently. And actually, if you see your GP and there's a lump and there's concerning features, you'd actually be referred under a 2-week wait, cancer referral, and they would see you in clinic. Within 2 weeks, you'd have images done, not necessarily just another mammogram. They might do an ultrasound scan and actually take a sample of that lump to be able to diagnose you and see. So just don't rely on a normal mammogram. If you have symptoms, you need to be assessed again.
Thank you.
Okay, this one's for Dr. Joshua. Why exactly are black men more susceptible to certain cancers, as mentioned in the talk? Why is that?
This is going to be a quick answer. We don't know. They don't know why prostate cancer is a higher risk, actually. I don't know if anyone else has any further information about that, but from my knowledge and my research, yeah, it could be, yeah, possibly genetic. There's a genetic component. Yeah, yeah.
Yeah, it could be diet too. My dad passed away because of the same disease. And we looked a lot at his diet, but obviously that's a study of one. But yeah, I do think the Caribbean diet as well could potentially play a role, but that's just my personal feeling.
Yeah.
It's interesting about the diet thing as well because it's higher risk in Afro-Caribbean men, then it was followed by white men, and then Asian men actually is a lower rates of prostate cancer. So we have similar diet in a way to some of the Asian populations. So I think it's just out for the jury. I think we need to do more research on it. The screening programs as well. There's a commissioning group, screening committee that decide which conditions they're going to screen. There's so many conditions you can screen for, and they decide which ones are profitable because it all goes down to resources at the end of the day, it does. And they choose which ones has a good screening test. For example, prostate cancer with the blood test, the PSA, is not a very specific test for prostate cancer. So you have to have a good test for screening. So it just varies really in that way.
I'm not sure if this is related, but prostatitis is something I was thinking about. If I'm not saying black men are more promiscuous, but if they were and they were picking up more STIs, then we have this term called prostatitis, where there's inflammation of the prostate due to sexually transmitted infections. So that could play a role. Not entirely sure, just proposing it.
Thank you. We've got another question here about cervical screening. If a woman is a virgin, does she still need to have the cervical screening? Dr. Tosin.
Okay. By argument, majority, if not the majority of cervical cancers are linked to high-risk HPV, and that's what the smear test is to pick up on. So if someone hasn't been sexually active, technically they would not have had exposure to HPV. But I would still see it as this is an opportunity for someone to check your cervix looks okay. So I still wouldn't. You can opt out of it if you feel that, okay, actually I'm likely to have had any exposure to, and you can opt out. But it's an opportunity for health screening. Someone actually for the first time has a look at your cervix. It's never been looked at before. There's a possibility that in a rare case, it might have been a non-HPV caused cervical cancer that is by chance picked up by someone just having a look at your cervix. So it's not like it's technically an invasive procedure. So if you wanted to avoid it and you feel like you're satisfied that you've not been exposed to it, then fine. But I would still see it as an opportunity of health screening. So I would still say go for it.
Okay, is there any other overall health checks that can be taken which goes beyond the annual health check? So that's probably looking at private or NHS checks. Dr. Clarke, do you want to take that?
Can I pass?
Yeah.
Dr. Danielle?
Okay, I think on the NHS screening, anyway, there are 11 conditions that are screened, and some in newborn, and also some in the pregnant ladies. Again, is to pick up diseases early. And that is what the screening test intends to do. It has to be common enough that it impact, the majority of the population. And also we have a good test that's going to be sensitive enough in picking up the condition, and also, doesn't muddle the water, doesn't tell you things that aren't there. essentially. So that's what this screening test is intending to achieve. Other more common thing that gets screened is diabetes, eye screening, okay? So outside of those common 11, of course, depending on, how perhaps wealthy you are, you can be encouraged. And again, like I said, those who are healthy live, longer, and that perhaps play a part. And also your family conditions, matters as well. Those who say, let's say for instance, cystic fibrosis. We don't get it in the black community, but within the white community, if your family is prone to it, then you're going to be screened for it. Like I said earlier on as well, like let's say someone died in their sleep. It's not normal. And if you have that sort of family history, you'll be invited to have like heart screening, for instance. So depending on the clinical situation, depending on individuals, people get offered more screening than the general population. But what screening shouldn't do is to induce, anxiety. That is part of the checklist in screening as well. So if, it's a condition that we don't think you're likely to suffer, then you won't be offered it. But of course, various people have health-related anxieties for different reasons. And if you feel it's something you want to bring up with your healthcare practitioner, then it's something I'm sure they'll be open to discuss with you.
Okay, someone asked another question about BMI. You mentioned, Nikki, about 19 to 25. This person's wondering, is that the percent of fat to muscle? What does that number mean?
No, really good question. So BMI, body mass index, is basically, are you a healthy or unhealthy weight for your height? And just to add, it is a guide. It's not measuring muscle. It's not measuring fat or anything specific apart from weight to height. So it's more of a guide. And as we were discussing earlier, there are other ways you can check if you're healthy. That could be waist circumference, waist to hip as well. There are other methods, but I guess in the UK especially, we use BMI as the guide. And it's basically if you are a healthy weight for your individual height. And I know it is very broad, but it just gives an idea, and that's what is used for a lot of medical, I guess, it's used as a medical benchmark. I don't know if anybody else wants to.
And for Dr. Clarke, is there any natural ways of controlling hot flushes and symptoms of menopause? And there's another question related to that.
Fine, thank you. Can manage hot and cold flushes during menopause. Okay, fine, they're the same. Ways to manage menopause. With the flushes, unfortunately, because it's controlled by the hormones in the body's going through a reduction of estrogen, and then all of a sudden there's this burst of progesterone, and what the progesterone does is take the body temperature up 1 to 2 degrees. So in that respect, it's hard to control, and this is where women go for the hormone replacement therapy, because they just don't want to suffer the symptoms. But of course, to then go for that option carries its risk. So my advice would be to avoid the tablets of hormone replacement therapy. And if you're really, really desperate, or you've got organs that are bothered by the menopause, then go for the creams. They're less risky.
I think like some of the stuff you mentioned diet-wise, the estrogen-based foods can sort of try to add some benefit. But I mean, there's the other healthy lifestyle stuff that you're able to do, exercise, making sure your diet is good. Because if you're already at a higher temperature, if you're at a lower weight, that might benefit as well. Also, you don't necessarily have to go for hormonal replacement therapy, because you have to think about people that have risk factors for breast cancer. They might or have had breast cancer before, they wouldn't be able to have the hormone-based replacement. So in some cases, antidepressants are also used for symptom control, not necessarily for depression, but studies have shown they can also help with hot flushes. So that's also another option. If you're trying to avoid the hormones, antidepressants are also used for treatment as well.
And also, just to add some little tips, and we all know our body's best, and so caffeine as well can sometimes, or reducing caffeine intake as well. So this is all anecdotal, meaning there's no research to support it. It's very personal and individual, but that can help as well. And just simple things, just like having the windows open or having a fan, just can help alleviate. So just general things that can help. Another thing that I read was just wearing layers. And I know it sounds really weird, like, oh God, layers when I'm going to be hot. But then at least you can take off, and just try and manage rather than remove the actual symptoms, especially when it comes to hot flushes.
I'd like to also add, in your workplace, you can also speak to HR and your managers about menopause, and they can make work-related adjustments at your workplace. Some workplaces are also doing talks about menopause and what support can be offered in the workplace. And some people's workload is changed during that time, because some people find it difficult to retain certain information. So there are changes that can be made during that time if you ask. Another question is it suitable or advisable to take magnesium as a supplement? Who would like to take that one?
I would say, before taking any supplement, just go and discuss with your GP, because magnesium is one of the salts. It can potentially destabilize some things or interact with your regular medication, particularly if you have multiple medications or you have previous history of issues. Just go and check. I don't know the benefits of magnesium, but I'm sure there is some benefit somewhere, but certainly just to check for interactions with any of your medication, or if it might put you at risk if you have particular medical conditions. So just play it safe.
Yeah, definitely would concur speaking with your GP first, as they're aware of your medical history, your medications, and all that comes with that too. In terms of supplements, for me, I would recommend a multivitamin, multi-mineral supplements in the first instance anyway. So they're just OTC, over-the-counter supplements that you can purchase from the shops. And then anything else specifically, definitely always speak to your GP before you make that change.
Thank you. Someone's put here, I understand that HPVI is to be taken for girls, but their sons are being offered it at school. Can you please advise why?
So the vaccination, I think what you're mentioning there, is essentially women get the HPV from somewhere. So if they're having a sexual interaction with a male, it's the male that can potentially pass it on to them. So it's just generally trying to reduce the amount of HPV that is out there, to reduce the risk of it now affecting women. So essentially that's the reason why they're now offering it also to young boys as well as young ladies. It's just helping reduce the transmission overall. That's the purpose of it.
Okay, we've got another question here. My daughter has been diagnosed with osteoarthritis, no cause established. What tests or other checks can be done to check the cause for this?
I'm not sure who's asked, but if it's a daughter, I'm assuming they're a young person. So if they've got early onset did you say arthritis or osteoporosis? Arthritis. So you can ask the GP to check for other inflammatory conditions. It could be that they have issues with their thyroid, with their adrenal glands, other hormonal or inflammatory conditions could be going on with them. And it's really important as well to check their hormonal levels, because it could, I know for osteoporosis in young women, it could be a sign of early onset menopause as well. But yeah, I would ask your GP to do a full screen. All you need to do is, when you book your appointment, ask for MOT blood test and just ask them to check every other organ to make sure, you know, you find out why this young person's had early onset osteoarthritis.
So I have here, how likely can a child as young as 4 years old become mental health? Parent have been through mental health at 9 years old. Can this be transferable? First of all, we all have mental health. In terms of mental health difficulties, we wouldn't really diagnose that at so young, at 4 years old. You might see some onset, you might see some difficulties around anxiety, there might be difficulties around the behaviour. Those are things that need to be monitored initially at school. So you need to speak to your school SENCO, and the school SENCO would be able to get professionals involved if they need further advice. So one of the professionals could be someone who's like me, an educational psychologist, who might look into the situation a bit more, might observe your this child. They will also take a developmental history, family history, and yes, you are right in the sense that you know, mental health can run within families as well in terms of mental health difficulties, but you can't make that assumption. So it's about getting the right professionals involved in the early so that that child can get the right intervention to support and hopefully make progress. Vitamin D supplement, how much should we be taking? There was also another question about how do you get the right balance of being able to get sunlight, like you said, on the skin and not get cancer, skin cancer. So maybe for Nikki initially.
Okay, so vitamin D, the recommendations are 10 micrograms a day, which, like I said, with vitamin D, dietary sources are limited, so I would recommend a supplement. General supplements can contain the full 10 micrograms or 50% of the RDA, so 5 micrograms. So, yeah, that's how much is recommended for people of darker skinned or those more at risk of vitamin D deficiency, like the elderly, the housebound, those who cover fully for religious purposes potentially. They would be recommended to take it all year round, and others are recommended to take the supplement now in the winter time, so from September right through till March, April. So that's the amount. Yeah, so the question was, would I recommend cod liver oil? Yes, cod liver oil is more for the omega-3s. You may find it contains a little bit of vitamin D in there, but it's a completely different supplement. So it would be more for the omegas, which is the healthy fats. But yeah, if I recommend it, currently because the population isn't eating enough oily fish, then yes, I probably would say take a supplement of cod liver oil. Or any oily fish oil, for that matter.
Sorry, a question about vitamin D. So I was diagnosed with I didn't have enough vitamin D because I'm fair skinned, I sunburn, so I'm always putting sun cream on. So would I always have to take? I had a high dose. They gave me a high dose, and then they said I have to take like the 10 micrograms. Would I have to do that all the year through?
Yeah, obviously speak with your GP, but based on what you've just said, and it's a really good question because it's normally, you know, the other way. So fair-skinned, yeah, if that's the case, after speaking with your GP, it would be likely that you would have to take that supplement all year round, potentially. I can't remember the B part of the question, but I think it was to do with sunlight.
Getting the balance of getting direct sunlight on the skin, but also avoiding cancer, which is why people are using the sunscreens and avoiding getting burnt, etc.
So really good example in that if you are using the sunscreen, there is a risk of you not getting enough vitamin D, but being protected from skin cancer. So it really is that balance. And we were talking about how, you know, not going out potentially when it's too hot or... Yeah. Can do, yes.
Yeah. Do you want to, did you want to say something? Oh, okay. Yeah, so Elder Chris, I heard what you said about for those with more melanin, it is thought that we are more protected from the rays of the sun. However, we're not protected from sun damage. So we can still be in the sun for too long, and any skin cell that is damaged, the skin is the biggest organ of the entire body. If it is damaged, then it can proliferate and form abnormal cells. So it's really just about getting a balance and not getting burnt, even though we do have a lot more melanin than our Caucasian counterparts. One of the best ways, apart from the sun, is to just check with your GP what your vitamin D levels are. If they are insufficient, so we have insufficient, deficient, or normal. If they are insufficient, then the GP can give you a massive loading dose of vitamin D. And they load you up for 6 to 7 weeks and get your vitamin D right up. Vitamin D also acts as a hormone in the body. It's just an amazing vitamin. It's more than a vitamin. It's an immune modulator. It controls a lot of the immune system as well. So find out from your GP where exactly is my vitamin D level. And then once your vitamin D is at a normal level, the GP can then keep you on maintenance doses, and that's just a regular dose every day, 800 international to 1,000 international units a day. So, the answer about can black people be at risk? Because genetically speaking, a lot of us are actually quite mixed, you know. We carry a very, very small risk. Wasn't once known or communicated, but it is something we need to be mindful of. But we are more protected, so don't want you to panic either. Yeah. I think there's just a couple more questions. Tosin, I don't know if you want this. It's breast cancer. What if I have discharge from breasts when I press them, squeeze them? If the patient is not a lactating woman, then I think you can answer. Yeah.
So if you're stimulating the breast, it can be normal to get some material come out. But the issue comes if you're having fluid, if you're having blood, if you're having stuff come out and you're not stimulating it, that's abnormal. But I would say if you're worried, then just go and see your GP anyway, because you're not going to lose anything apart from, you know, a 10-minute appointment to go and discuss it if you're concerned. But it can be normal and you're not lactating. If you stimulate a breast, some material might come out. But if you're not stimulating it and you are getting stuff, then that's abnormal.
I think we've just got one last question. Sorry, I think there were one or two we couldn't understand the handwriting. Really sorry. But we open the floor maybe for just 2 minutes because we need to get onto the workshops. So this question is, what test can I ask the health professional I think they're asking about bone test. Yeah, I think this one's about bone test. So with this, again, I would just say visit the GP. Before, as Nikki said, before you supplement with any supplementation, find out from the GP exactly what your calcium levels are, your phosphate levels, and your vitamin D levels. They're all important for good bone health. And based on your blood results, then the GP can advise you on how best to supplement. Does any other doctor want to add to that?
In terms of bone health as well, you also have to think about your family history. If you've had anyone in your family who, like a parent that has had a hip fracture, then you're at slightly increased risk. If you're on any if you have any condition, that means you're taking long-term steroids. You're also at increased risk if you've got rheumatoid arthritis. So there are screening tools that they can use, such as a FRAX score, which will calculate your risk and help us to sort of determine whether you're at significant risk to have something called a DEXA scan, which is a special form of X-ray that can diagnose osteoporosis. But of course, it's always helpful to have, in addition to that, your calcium level and your vitamin D level checked as well to help with that.
I think, as Dr. Clarke said, we can take 2 more questions. So if anyone from the actual congregation would like to ask anything. Alan, if we've got one here. Brian.
How would you weigh up the benefits in relation to cost purchasing organic foods, organic vegetables, fruits, or does it depend on what fruit? Basic question,
Yeah, good question. It's a hard one. It really is down to personal preference, and it's just to stress as well that organic food does still have the pesticides, and it still has it. It's just at very low levels. It really depends on your personal choice, what it is you're looking for in your diet. So some people just physically, they just can't afford it. And I would not want people to think they have to buy organic in order to eat healthy. But if you can afford it, and that's one of your priorities, then yes. In terms of fruits, obviously those with skin covering them, like bananas, where you don't eat the skin potentially, you may not get such a benefit because it's not affecting the inner, the banana inside. But those like apples, where you do eat the skin, you may want to choose organic for those. It really depends on your purse strings and your priorities, I'd say.
But also organic food, is it grown in different soils, so might it have a different nutrient composition?
Potentially, but research has shown that it's not significant enough to make a huge amount of difference nutritionally.
Right, thank you.
Okay.
Anyone else? One more there. Thank you. Just wait for Alan, please.
Just going back to your menopause, I've heard that men can have menopause as well. If they can, what are the symptoms and do they affect them in the same way? Do I need to buy a fan?
Very good question. So for men, yes, they do have adrenopause. But it's different to how it affects the women. So with the women, the estrogen drops right down to, under 10%, you could say. For the men, theirs only dropped down to about 50%. So that's why they don't get the huge symptoms. They don't need to get the fan out. And where the women stop ovulating, as we know, men can go on to have children until they're 99. He says hallelujah. But yeah, it's completely different. There are other physiological effects in adrenopause, but men don't need as much testosterone and androgens as when they are younger. So men, they need the testosterone to become men, to grow male pattern hair and all the other bits that men grow. The hormone's done the job, but it doesn't then suddenly plummet as it does for the poor ladies when they hit menopause. How do they know they have adrenopause? Because they don't present with overt symptoms as women do. And they have enough testosterone to get by. They don't need testosterone replacement. They just have less of it. So they might start to lose hair. There might be other symptoms that they go through.
I'm not there yet, so I don't know anything about it.
Been there, done that, got a t-shirt. Yes, I mean, like Cheryl just said, yeah, subtle sign will include losing hair. In fact, for the men, it probably starts much earlier than the women and often goes unrecognized. Not only is the testosterone level lower, it may not be as effective. And the testosterone level are, often high enough to continue to have the reproductive life, but the quality of the reproduction as well matters. It could be evidenced by erectile dysfunction, premature ejaculation. That could all tie up into the same baggage. But those two things I just listed, they are complex condition that we're still trying to understand. We can't put it all down to the reduction in testosterone, but those are the linkage thus far. And of course, you'll agree with me, men do have their own mood swing as well. You do talk about grumpy old men, It happens, as time goes on, men become more and more and more reserved, right? Could be the way that men are expressing, the lack of, androgens. So, complex question, one still under study.
Thank you everyone for your questions. We'll draw that to a close now. For those who would like to participate in the continued mental health workshop, which is the solution circles, if you could meet at the back there, and the rest of you can wait by the stations for your observations. Thank you.
Thank you.